with diabetes. These are my disclosures. I am a consultant for RedDress Limited. So here we have a perfect example of a neuropathic ulcer in a patient with diabetes. Obviously, you can see that the wound needs to be appropriately debrided. There's a very thick, hyperproliferative wound edge. And of course, I'm certain that everyone in this audience is very familiar with this type of wound. So give some thought to how you would treat this ulceration, particularly if the wound did not respond to standard care. I think throughout this lecture, you may get some additional information which may help move these wounds out of the inflammatory stage of wound healing into a healing trajectory. So when you think in terms of diabetes, obviously amputations and lower extremity wounds, unfortunately, often occur. In the United States, it is a very significant problem. But when you think in terms of how individuals view patients with amputations, very often they think in terms of the athlete who may have gotten injured in a car accident, or perhaps a soldier who was injured in war. And you can see this individual in very, very good shape, wearing very expensive prosthetic devices costing thousands or maybe even hundreds of thousands of dollars. And again, this is the impression that many people have of an amputee and exactly what limitations or other activities they can do. But in actuality, we're really dealing with this situation. We're dealing with a very sedentary individual. If you notice, the prosthetic device is not even on the patient's body. It's very, very often used as an ornament. And unfortunately, these patients decondition very quickly and often succumb to their illness in 5 years, because this is really the problem. So certainly something that we see on a very unfortunate regular basis. When we think in terms of how to deal with chronic wounds, obviously we need an algorithm in place to be able to help us work through the maze of healing. Very often these algorithms are very complex. The wound bed preparation model is something that is extraordinarily important, because not only is it simplistic in nature, but it's very powerful. First and foremost, certainly we want to find out if the wound is even healable. Secondly, we want to make certain that we're actually dealing with an ulceration and not something else like a skin cancer or vasculitis. We want to address patient-centered concerns. What's the patient's vascular status? What's their lipid profile? Are they compliant? Do they see their medical doctors on a regular basis, et cetera, et cetera? And once we get through this holistic approach to treating patients with this kind of problem, then we can move to the wound itself. And it's a very easy acronym to remember how to approach these ulcerations, and that is DIME. You may have seen it as time, T for tissue. DIME perhaps is a little bit more explicit as to what this actually means. D for debridement, I for infection or inflammation, M for moisture balance or imbalance, and E for wound edge preparation. And wound bed preparation is really a very important step in not only treating wounds, but protecting them against infection. Unfortunately, despite heroic efforts, very often standard care just does not work. And we are relegated to using more advanced therapies to really turn a light switch on, if you will, to activate the wound and to move it into a healing cascade. So our objectives are straightforward. We're going to first and foremost explain the epidemiology of the diabetic foot, at least in the United States. We're going to list the differences between acute and chronic wound biochemistry and talk a bit about the extracellular matrix. We're going to learn about autologous blood clot therapy and how it's been used to accelerate wound healing. And we're going to do this basically by hypothesizing the mechanism of action of how this topically applied blood clot therapy actually works. Lastly, we'll review some cases. So in the United States in 2020, diabetes affected about 34 million people. It's greater than 10% of our population. It's projected by 2050 that this will increase to about 12% of the population. And the last recorded history of death was in 2007. And at that point, it was the 7th leading cause of death in the United States. However, looking beyond the US, certainly this is a very significant epidemic, which is global in nature. And by 2030, the number of people with diabetes is going to rise exponentially. And I hope you're sitting down when I show you this number, because it's 500 million people. 500 million people will succumb to the diabetic condition. So when you think in terms of complications in the diabetic patient, the diabetic foot ulcer is right at the forefront. In fact, it's the most common reasons why an individual would be hospitalized. The annual incidence is probably greater than 4% at this point, and the lifetime risk is between 25 and 30%. So if you look at that 500 million people, the lifetime risk of 25 to 30% is just monumental. 15% of diabetic foot ulcers result in lower extremity amputations. 85% of lower limb amputations in patients with diabetes are unfortunately preceded by an ulceration. And of course, peripheral neuropathy is the major contributing factor to the ulcer. But the reason why patients lose limbs is because of infection and peripheral arterial disease. There are 1 million amputations globally in patients with diabetes. That is calculated at 1 every 30 seconds. So if you think about how long we're having this conversation, every 30 seconds, someone in the world is losing a piece of their body to this illness. So how serious is this? Well, this actually was compared to some cancers like breast cancer and Hodgkin's disease. And what this study by Armstrong and colleagues in 2007 showed is that nearly half of all neuropathic ulcers resulted in death within 5 years. And this relative risk was actually greater than some cancers. So when you look in terms of this diagram and you say, well, yes, these patients are dying, but it isn't a neuropathic ulcer, it's the diabetes. And of course, that's a common misconception. And one has to look no further than this next study done out of Norway on a very large population set, controlling for disease factors in diabetics versus non-diabetics, and looking at mortality risk. And what they found that there was greater than a 2-fold increase in mortality in diabetic patients with foot ulcers as compared to non-diabetic patients. But more importantly, in patients with diabetes, the presence of a foot ulcer alone increased mortality by almost 50%. So I think it's safe to say that just having a neuropathic ulcer in the foot of a diabetic patient is a marker for death. Now, when I wrote this article in 2010, I got a little flack for it because, again, the belief at the time was that it was the diabetes and not the foot ulcer that was causing the patient's demise. And it wasn't until 2016 when David Margolis and colleagues published this article in Diabetes Medicine that stated that this could not be explained by any other common risk factors. So looking more granular, what is the problem? Well, just looking at the wound healing cascade, of course, the first and foremost is what you see is hemostasis. Obviously, you want the blood to stop. You don't want the patient to bleed. So hemostasis is the first line of defense. And this is followed by the inflammatory phase of wound healing, the proliferative phase of wound healing, and ultimately the reparative or remodeling phase of wound healing. And keep in mind that patients who have chronic or stalled wounds are stuck in the inflammatory phase of wound healing. So just looking at this cartoon, you get a sense of how complicated this process is. These are overlapping phases. They're all occurring simultaneously. But when you look at this, I kind of think in terms of how I would look at my computer screen or my television set. I only think about it, and people only think about it when it's broken. And really, that's what happens when you have a chronic non-healing wound. So first and foremost, you have unresponsive or senescent cells. And if you don't do anything to change that paradigm, you wind up with replicative senescence. You have a very slow turnover of cells. You have non-migratory hyperproliferative wound edges. This prevents keratinocytes from moving across the wound to facilitate reepithelialization. High levels of proteases or proteolytic enzymes like MMPs and serine elastase. In an acute wound, these are seen at very low levels, but in a chronic wound, they're seen in very large numbers. We have deficient or unavailable growth factors. But even in those individuals where you have adequate growth factor production, very often the receptor sites that are required to create a physiologic response are really not functioning well. And lastly, we have bacterial interference. Higher levels of bacteria keep the wound stuck in the inflammatory phase of wound healing. Bacteria also release their own enzymes, endotoxins and exotoxins. So even though we're talking about the diabetic foot here, all chronic or stalled wounds really share, for all intents and purposes, a very common biochemistry, irrespective of the etiology. And now we're dealing with another wrinkle, and that's the biofilm. Biofilm basically represents a heterogeneous mix of virulent bacteria that are sitting in a kind of a tube called the glycocalyx. It's basically protective in nature so that antibiotics and topical agents are impervious to it. So when you think in terms of wound healing, let's talk about standard care, offloading, debridement, and moist wound healing. This was a meta-analysis done in 1999. It was over 20 years ago. And David Margolis looked at healing rates at 12 weeks and 20 weeks with standard care. And what he found was that less than 25% of patients would heal in 12 weeks with standard care, and about 31% would heal at 20 weeks. This gave the clinician a very realistic assessment of what standard care could actually do, and certainly created a paradigm indicating that there are tremendous challenges involved in treating these lesions. Now, fast forward 20 years, Parks and colleagues did another updated meta-analysis, even of a larger set of randomized clinical trials, and they found about a 15% healing rate at 6 weeks, about a 33% in 12 weeks, and a 43% healing rate in 20 weeks. Now, even though this was better than Margolis looked at 20 years ago, it really wasn't that much better. The endpoint still remained very low. So again, standard care very often doesn't work, and we have to look for other alternatives. So how do we know when to use advanced therapies? Well, in the diabetic patient, we did a study in 2010 looking at a surrogate endpoint of 4 weeks to determine whether or not wounds would heal by week 12. There was a study previous to this done in 2003 by Peter Sheehan. And what we found was that if patients didn't reach 50% area reduction within the first 4 weeks, the likelihood of healing was only 2 to 5%. And if you reverse those numbers, 95 to 98% of patients will not heal by week 12 if they don't reach that 50% endpoint. But this was really a negative predictor of healing, not a positive predictor of healing, because even those patients that reached the 50% threshold, almost 50% of those didn't heal anyway. So we needed to look for additional surrogate endpoints. So what did this tell us? Well, first and foremost, clinicians should have a sense of urgency to move to an advanced therapy very early in the treatment regime. But it also it made a case for us to look to the next 8 weeks to see what we could do to find some additional endpoints. And in fact, we did. What we found was very interesting. We found that ulcers that failed to progress or worsen by weeks 4 to 6, and those that failed to achieve 90% area reduction by week 8 were unlikely to heal by week 12. So now we have 3 surrogate endpoints. We have 50% in 4 weeks, we have failure to progress by weeks 4 to 6, and we have failure to achieve 90% area reduction by week 8. So there's no reason to practice what I like to call dartboard medicine. We now have validated endpoints that you can use to help make decisions about when to use an advanced therapy. So let's turn our attention now to the extracellular matrix. The extracellular matrix is the largest organ in the skin. It basically is gelatinous in nature. It contains collagen, fibronectin, glycosaminoglycans, etc. What it does, basically, it creates an infrastructure for cells in the wound. Now we turn our attention to proteases. Proteases are protein-degrading enzymes. There are two major categories: matrix metalloprotease and serine elastase, or human neutrophil elastase. Now, why is this important? Because in the inflammatory phase of wound healing, neutrophils are the predominant cell. So if the wound is stuck in the inflammatory phase of wound healing, the likelihood of pouring out serine elastase is very, very likely. So we have two categories. They function optimally under normal physiologic conditions. And in fact, if there is no wound, they synthesize and store in an inactive proenzyme. They're often controlled by tissue inhibitors of metalloprotease. But if they are left unchecked, they can collectively degrade the entire extracellular matrix. So not only do you have this big hole now and you have difficulty with healing, but you also are losing out on another very important dynamic, and that's dynamic reciprocity. Dynamic reciprocity basically means that there is a communication between the extracellular matrix and other cells in the wound, like endothelial cells and fibroblasts. If the extracellular matrix is destroyed, you now have a disconnect in this communication, and the wound will not heal. So it's very, very important to keep these concepts in mind as we move forward. So thinking in terms of how to deal with this extracellular matrix, particularly in a chronic wound, autologous blood clot tissue certainly may serve to bolster and even replace the extracellular matrix, thus reestablishing dynamic reciprocity. Now, moving towards the clotting cascade, obviously this is a very complex dynamic where it's out of the scope of this lecture, but there are 13 clotting factors. And of course, when you have damage to an area, you will basically get the exposure of circulating platelets. Platelets are the first cell that go towards the wound. And of course, they will release platelet-derived growth factor, creating a platelet plug or fibrin plug. You have an intrinsic pathway, which is an injury pathway, and an extrinsic pathway, which really covers everything else. Now, this complement cascade has been shown to play a very pivotal role, not only in inflammation, but in augmenting wound healing. Something else of extraordinary importance is the macrophage concept. Now, macrophages, as we know, are white blood cells, and they phagocytize bacteria. So basically, they kind of clean up the wound, if you will. But macrophages actually can be broken up into two types. M1, which is pro-inflammatory, which we see in the inflammatory phase of wound healing. And as wound healing progresses, we move to M2, which is anti-inflammatory. And this is basically referred to as dynamic macrophage plasticity. It will play a very, very important role when utilizing the topically applied blood clot tissue. So again, this is just a picture of the components of blood, of course, very complex in nature. So I think it can be hypothesized based on the literature that autologous blood clot tissue can do many things. First and foremost, it clearly can function as a tissue sealant and may in the future even act as a drug delivery system. It produces multiple growth factors which stimulate tissue vascularity via the concept of angiogenesis. It prevents infection via macrophages, and it acts as a scaffold to bolster or even replace the extracellular matrix. It also fosters wound contraction because it hugs the edges, and it could in fact stimulate pluripotent stem cell recruitment. Here's just another example of those phases of wound healing. And of course, initially, a traditional or standard wound care is appropriate. However, if the wound fails to respond, an advanced dressing may be appropriate, like a collagen dressing as an example. But of course, again, if you have no significant response, you have to move to an active therapy. An active therapy actually turns a light switch on, if you will, and creates a physiologic reaction and a physiologic response to actively promote healing. So it can be hypothesized, and it's very likely that the extracellular matrix and the chronic wound bed actually signals the blood clot to give the wound what it needs when it needs it. this is an example of what ActiGraft looks like, this autologous blood clot therapy. We also have angiogenic stimulators and inhibitors, and there are many of them, including tumor necrosis factor alpha, platelet-derived growth factor, etc. Now, there is a concept of therapeutic angiogenesis, which is aimed at locally applying growth factors in excessive amounts to override existing inhibitors. And this is exactly what this topical blood clot therapy can do. It can clearly be hypothesized that topical blood products have been shown to produce multiple growth factors in large amounts that clearly could stimulate angiogenesis. This is just an example of what that may look like. So turning our attention to cell and tissue-based therapies, there are three basic types: autologous, which includes split-thickness skin grafts, epidermal blister grafts, and platelet-rich plasma, or PRP. We also have allogenic topicals, like living skin equivalents, cadaveric allografts, and certainly a whole host of amniotic membranes. And lastly, we have the xenografts, which could either be made of porcine, bovine, bladder, equine, etc. But there are significant benefits to utilizing autologous therapies. Number one, they're biocompatible. Two, they reduce the risk associated with disease transmission. And three, there's a minimal chance of rejection. So looking at autologous blood clot in very broad strokes, it's a protective covering. It's a biologic scaffold. And by that, I mean that it allows the movement of keratinocytes and fibroblasts through the matrix. It stimulates the normal wound healing cascade by bathing the area with growth factors and other substrates required for healing. It's an unlimited resource. This is a point of care therapy. You draw blood from a patient and you utilize it at the time that you need it. Again, it's an unlimited resource, and there are articles that have recently been written that show that it's cost effective. Here's an example of an electron microscopy, just looking at this stromal matrix, and you can see those keratinocytes sitting in this matrix, moving across the matrix, truly representing a true cell and tissue-based therapy that allows proliferation of cells and creates wound contraction. So let's look at some of the evidence. Well, in 2016, obviously, there was a pilot study done initially looking at 7 patients with multiple and serious comorbidities, 9 chronic wounds, treated with 35 clot matrices. 78%, or 7 out of 9 of these wounds, actually healed, and it was concluded that this therapy was certainly very effective and also safe. There were no systemic adverse events that had occurred, but clearly a larger clinical trial was necessary. I was involved in this trial in 2018. It was an open label pilot study. It was 20 patients. And we looked at the proportion of patients that healed over 12 weeks. And we, of course, we look at a very important result, and that's the intent to treat group, which was 65%, the per protocol group about 72%. But it was also interesting to look at the percent area reduction based on the study that we had done in 2010. The intent to treat group at 6 weeks was about 67%. The per protocol at 12 weeks was approximately 76%. And the mean time to healing was in essence the same, somewhere between 56 and 59 days. Now, what's important to understand is, again, this was an open label study. Currently, there is a pivotal randomized controlled trial comparing autologous blood clot tissue to standard of care. We're going to be using and are using debridement, a cam walker, and foam to create moist wound healing. And this is currently ongoing. We also have a very large registry that is underway utilizing this therapeutic regime. And we've had very, very favorable results in some of the most complex wounds, including wounds that have exposed tendon, muscle, and bone. This was an analysis of 3 prospective open label trials utilizing autologous blood clot tissue, clearly demonstrating not only efficacy in healing acute and chronic wounds, but it did it both in vitro and in vivo. So let's talk about how this product, this ActiGraft, would be used. Well, it's very simple. What you do at point of care when the patient is sitting in the treatment chair, you draw blood, 18 milliliters. Actually, it's a little bit less now with some of the newer kits. You create a clot. This is usually done in this little dome that you see with calcium gluconate and kaolin, and it creates this very malleable but very robust clot. You can actually cut it. It will ooze a little bit, but you can cut it. You can shape it to size, or you can just put it on as a full clot. And basically, you stabilize it with steri strips and then a dry sterile dressing. Here's an example of what this would look like on the plantar aspect of a patient's foot with diabetes. This patient had a very stable Charcot arthropathy with a non-healing wound. You can see that the wound is beefy red, so this wound was clearly prepared to accept an advanced therapy. And that's a very, very important concept behind wound bed preparation. We want to prepare the wound because if the wound is full of MMPs and serine elastase and bacteria, it will not work as effectively as if the wound has been cleaned up with the wound bed preparation model. Although we have found that utilizing ActiGraft on a wound that is not necessarily prepared has also garnered significantly good results. Now, I show you this slide because it really shows you how wonderful nature is. I mean, this is just a beautiful clot. It's a topically applied clot that I utilized on the plantar heel. I must say, when I first started utilizing this therapy, I had two concerns. Number one, because it's a fairly full and robust clot, I was afraid that it was, as soon as the patient put any weight on it, it would just disappear. Secondly, I was concerned about maceration. Well, neither of those occurred. The clot basically dries up. And what I found, which was really very interesting, was there was a little hole that was created in the center of the clot for that fluid to drain into the secondary dressing. We saw no maceration at all. So let's look at a couple of case studies. This is a 77-year-old white male who has type 2 diabetes, neuropathy, peripheral arterial disease, a whole host of medical problems, including a very long history of smoking. He had the wound for 30 weeks. His ABI was 1.11, and all kinds of therapies had been utilized, including HBO and even a split thickness skin graft, which did not take. And of course, the patient was debrided on a regular basis and appropriately offloaded with a boot and even a total contact cast. The wound still failed to resolve until ActiGraft was utilized. And this is day 0, day 35, and day 78. And just looking at the decrease in centimeters squared over that period of time, this wound went on to completely reepithelialize. Now, this is a 98-year-old white male. Now, in the United States, we're seeing more and more patients who are in this age group. You know, when I first started practicing, I didn't see diabetic patients over the age of 60 because they didn't survive. Well, that's changed now with the newer medications and newer therapies, et cetera. So it's not uncommon anymore to see a diabetic patient that is in this age group. This patient had congestive heart failure, had all kinds of problems, and in this case had a stage 4 right heel ulcer that actually was diagnosed with an MRI as osteomyelitis. The patient was on long-term antibiotics for an extended period of time, did not do well. He had all kinds of topical therapies applied, including those that we utilized to decrease odor because there was some malodor there, and even negative pressure wound therapy was utilized here. Patient wore a boot for offloading purposes, and unfortunately was offered an amputation. He refused. The patient, again, was treated with ActiGraft, and you can look at what occurred over between day 1, day 13, and day 19. The wound completely reepithelialized during that time frame. Now, this next patient is kind of an anomaly in my view. This is not a patient of mine. This was a patient of Dr. Wahhab's, but it's such an interesting case that I wanted to present it to you. This is a 67-year-old female with end-stage renal disease. Now, we all know that end-stage renal disease is an independent predictor of non-healing in patients, particularly with diabetes, which the patient also had. This was coupled with peripheral vascular disease. He had had gangrene of the great toe. He failed the first ray amputation, and he had an open transmetatarsal amputation, which did not heal. He was offered an amputation, but refused. Now, what's interesting about this case is if this were my patient, as an example, I would have debrided this patient on a regular basis. I would have cleaned up that bone and would have tried various techniques to get this wound to heal, ultimately attempting to reapproximate the edges. But in this particular case, this physician decided just to treat with ActiGraft. So look at the progression over a period of 8 weeks. This wound progressed to such a degree that the wound really became acute in nature and then could certainly be treated with appropriate measures. So again, this is an unusual case. It's kind of an outlier, but it's something I did want to share with you because it really shows how significant this therapy can be. So in summary, topically applied autologous blood products clearly can augment healing. They stimulate growth factor production. They have the potential to mitigate infection. They bolster or replace the extracellular matrix. They're evidence-based, and I think that evidence continues to grow. We've had multiple papers published. We've had multiple posters, and the randomized control trial and the registry will certainly add to the body of knowledge with this particular therapy. It's very, very easy to use. It's a point of care a therapy. You use it when you need it. If the patient comes in and the wound is healed, or the patient comes in and the wound is infected, and you don't want to use it, you don't have to. It's not as if you have a product that you have to now find a home for. And of course, we have found through studies that it is cost effective. We also know that this could have benefit in many other areas. Complex wounds is an example. We're finding during the registry that wounds with bone, tendon, and muscle exposed are healing very, very nicely with this therapy. We may be able to use it in wound bed preparation, in limb preservation. There are physicians using flowable techniques where they're using it by injection into fistulas, into undermining, into tunneled areas, and it may also be utilized to prevent infection. So I truly believe that this is a therapy which will be very beneficial in many areas of wound management and limb preservation. Well, I thank you very, very much for your time, and I'll open the floor for any questions you may have.
Thank you, Dr. Robert.
You're welcome.
It was very clarified for us. Let me see if some attendants has question.
Sure.
Pessoal, alguém tem alguma dúvida? Alguém quer fazer alguma pergunta? Alguém que já utilizou o material ou não? Alguém que já tem alguma técnica, visto alguma técnica parecida, celular, queira acrescentar alguma coisa, fazer alguma questão? Fiquem à vontade aí. Vocês podem levantar a mão. Aqui embaixo tem um botão para levantar a mão ou fazer pergunta no chat. Fiquem à vontade.
Quem quiser fazer a pergunta direta, a gente habilita o áudio e o vídeo, se for o caso, tá bom? Podem ficar à vontade.
Any questions at this point?
Yes.
Doutora Cláudia, a senhora quer perguntar direto? Posso abrir seu microfone?
Tem alguma coisa no chat também, Jorge.
Vou só primeiro... Bom, Okay, no problem. Dr. Robert.
Yes.
Dr. Claudia asked, how can we do when we have an ischemic limb?
So first and foremost, we want to make certain that we can do whatever possible to reverse the ischemia, either with an endovascular procedure or a vascular procedure. But assuming that the patient is already optimized and there is nothing more that can be done, it is possible that this therapy may be of some benefit. Now, obviously, if you have a truly ischemic limb, there's not much that we're going to be able to do. But if the patient has some blood flow, and again, looking at the angiosome concept with artery to artery connection, sometimes we get lucky. And this therapy really could be beneficial. But again, the caveat is with very, very poor blood flow, it's unlikely that any therapy will really be beneficial, but certainly worth a try when you're out of options.
Okay. There are two questions that are a little bit similar. If it exists some contraindication for ActiGraft use, and if there is some infection, if ActiGraft should be avoided.
So, to my knowledge, there are no contraindications for using this because you're basically using autologous blood. You're using the blood from the patient. So the patient is not going to infect themselves. So there really are no contraindications to my knowledge. As far as infection is concerned, I think there is beginning to be some body of evidence that shows that we may have some benefit using this, particularly in conjunction with systemic antibiotics. And the reason is the blood clot itself has a tremendous amount of macrophages, and those macrophages can act through phagocytosis and through an anti-inflammatory effect as M2 to help mitigate infection. So it's not necessarily contraindicated with infection. Certainly, I think the wound needs to be cleaned up. Very often with a true infection, you likely will have to use this in conjunction with some type of systemic antibiotics. It really is dependent on the patient themselves. I mean, if you had a full-blown infection with an abscess, obviously you have to deal with that first. You have to clean the wound up and make certain that you're not going to do any harm. But once the area is cleaned up, patient is on antibiotics. This could be where we believe this could be an important adjunctive therapy.
Okay. One question: if the patient has some vascular problems, should it be treated before using ActiGraft? Do you think that it can combine both procedures? How can you see that?
So my opinion is that if you can improve the vascularity first, that's probably a better option. And the reason is, particularly in patients with diabetes, when you improve the circulation, the macrocirculation of the large blood vessels, sometimes it takes a bit of time for those small vessels to start to dilate in patients with small vessel disease and diabetes. So sometimes it takes a few days for that to occur. Also, the angiosomes, these three-dimensional blocks of tissue that we see in the foot, they're surrounded by choke vessels, and those choke vessels take about 72 hours to dilate fully. So my opinion is that if you can improve the vascularity first, I would do it. If you feel that you have no options, or you feel that you have optimized the patient to the extent possible and that no more can be done, and you feel the vascularity has been improved to the extent that it can be in this particular patient, then certainly utilizing this in conjunction would be appropriate, in my opinion.
Okay, and in your experience, do you make some blood tests before apply ActiGraft to see if the patient need to improve some nutrients or something like that?
In my opinion, there is no reason to do any additional blood tests. Obviously, if the patient needs nutritional supplements or needs, you find that the patient has an elevated white count, as an example, or the CRP is elevated, or the SED rate is elevated. Those are things that you're going to have to deal with. But because it's autologous and you're taking it from the patient and utilizing the patient's own blood, the caveat is, let's say the patient is very sick, and you're taking blood from them and you're putting it on. You may not get the exuberant response that you would from somebody who may be 45 or 50 years old, who maybe not be as sick, but it's still beneficial. So I think it's important to keep that in mind and to be realistic about the options that you have.
Okay.
Doctor, even in anemic patient?
Can you use it in an anemic patient? You can, but I think you have to keep in mind that it may not work as well. It certainly will work, in my view, and has worked in a large number of cases. But again, when you're dealing with someone who's sick and someone who's anemic, you may not get the robust response that you would get for someone who didn't have those underlying problems. Let's say someone who was just diabetic, or someone who had a traumatic injury, or someone who has venous insufficiency with a venous ulcer.
Okay. Talking about the Charcot case, do you recommend the deformity correction before try to ActiGraft, or try close the wound first and then correct the deformity?
It really is up to the surgeon. What I like to do is correct the wound first, get the wound to heal if possible, with offloading, with ActiGraft, with debridement, with wound bed preparation. Once that wound is healed, then I feel that the patient has a better chance of a good response from correction of the Charcot deformity. Although, some doctors will use them in conjunction. So it isn't contraindicated to do the Charcot reconstruction with an open wound. And certainly once that is done, you can use the ActiGraft over whatever remaining wound is open. So there really is no reason why you couldn't do it. My personal preference is to try to get the wound to heal first, if possible, or to get it small enough where I'm comfortable, and then go ahead and recommend the reconstruction.
In your opinion, is it possible to apply ActiGraft in patients that suffer with pyodermic gangrenosum?
So I've had 2 patients now where we've used it in conjunction with systemic therapy, and we've had very good results in those patients. So again, it's hard to make generalizations, or I'm not sure if it's generalizable at this point, but my opinion is, based on my own experience, is that utilized in conjunction with systemic therapy, either steroids or some biologic, I think could be very, very beneficial. Again, you have that M1 and M2 concept of macrophages, and you can get a very significant anti-inflammatory effect. So another thing to keep in mind, and something I did mention before, but worth mentioning now, patients with pyodermic gangrenosum very often have significant pain. And in my experience, I have found that utilizing this on a wound that is pyodermic gangrenosum by clinical diagnosis, that pain abates relatively quickly. I've actually had one patient who came in with extraordinary pain and left almost pain-free. Now, I'm not saying that will happen in every case. Some patients don't respond that way, but I do find, as an adjunctive therapy, this could be a very, very important adjunct.
Okay, and Dr. Robert.
Dr. Sergio.
Go on.
Dr. Sergio Chelsea has a question. Dr. Sergio, o senhor quer fazer...
He's in the hospital. He asked if he antiplatelet. No, I don't know how to spell it correct.
Oh, so if they're on antiplatelet therapy, like anticoagulants?
Yes, can influence the ActiGraft action.
You can, but no, that's fine. That's fine. So you can use it in those patients, but understand that it may take longer for the clot to form. or it may be a little bit more runny. You know, it may not be, the clot may not be as robust, but certainly we have used it in patients who are on various anticoagulants, and we've not had any significant problems other than the ones I mentioned. Again, you may not get that robust clot that you want. It may be a little bit more runny, or it may take longer to actually form the clot.
Maybe twice time than usual.
I don't know if it's twice, but I just think you have to watch it. It's kind of like baking a cake, if you will. You just have to watch it, and you kind of move that dome around to see whether or not that the blood is congealed and coagulated or not. It does often take longer, but we've had consistently good results. I mean, I can only think of one case when a patient was on, I think it was Eliquis, where the blood didn't clot. But other than that, we've not had any problems.
And Dr. Robert, I have one question. For you, is there some standard time to take the ActiGraft in the patients, or how long it to stay with the patient, or depends on the treatment or the patient?
So you're asking how long to leave it on, or how often to apply it? What?
No, how long to leave it on?
How long you leave it on? So right now, we don't necessarily have a dose response. So right now we're using it once a week. We're changing it once a week, and that's been very effective. Maybe we can use it twice a week. Maybe we can use it every other week. We're not sure. But at this point, the way it's being studied is it's being applied once a week, and that seems to be a very effective time frame. So applying it once a week, then debriding the wound again and applying an additional clot is the way that we're doing it at this point.
Doctor, have you ever tried another vehicle in ActiGraft except blood? Did you combine it with another substance or PRP or something like that?
Well, you don't need PRP because the platelets are already in the blood clot. So adding PRP would be redundant. I haven't yet used it in combination with other things. I do believe, and again, this is my own opinion, there's no evidence to support it at this juncture, but I do believe that it could eventually act as a drug delivery system as it starts to dissolve. So as an example, I envision, and again, this is just my own opinion, but I envision perhaps using an antibiotic in conjunction with the clot. And as the clot starts to dissolve and dissipate, that antibiotic would be released. Again, no evidence to support it at this juncture. We've not used it in that regard, but it's something that I, as an innovator, it's something that I kind of envision could happen in the future.
Okay. Alguém mais tem alguma pergunta? Okay, so Doctor, we would like to thank you a lot for your time. It was a very special moment for us that is just to start our journey with ActiGraft. For sure, in 1 or 2 months, a lot of new questions will be done, and we hope that we have a new chance to talk with you.
Of course, of course. It was my pleasure to be here, my honor, and thank you very much for inviting me.
Yeah, you are very well invited to come to Brazil one day if you want.
I would hope so. Yeah, that would be wonderful. Yeah.
Moshe can provide it. So, and the audience is thanking you also.
Very good.
And do you have a last recommendation or a last or something that you would like to say for the doctors that are just starting to use or had some idea to use the ActiGraft?
So my recommendation is really to keep an open mind. This is kind of a very simplistic but very powerful therapy. I think we're just beginning to realize how useful it will be. You saw kind of a partial list of some of the things that we're currently looking at, and and as doctors begin to use it, they will come up with additional ideas and additional potential uses for this very important therapy. So that's what I would leave you with. And again, I wish you all the best. And thank you again for your time.
Thank you,
Thank you.
doctor.
You're
Thank
welcome. You're welcome.
Thank you, Dr.
Bye-bye.
Mike. Thank you,
You're
Moshe.
welcome.
Bye-bye.
Thank you. Thank
You're
you, team.
welcome.
Thank you, doctor.